Hello everyone, my name is Deepu Gowda. I'm the course director for Foundations of Clinical Medicine tutorials, and I want to welcome everyone to be faculty members in this fall tutorials course. I want to spend this time with you just discussing the course and orienting you to what the fall curriculum looks like. These are the members of our team. On the left is Sarah Wilson, our course coordinator. David Kessler is in the center there, the associate course director, and I am on the right. These are the things that I want to go over in this orientation: the overall course goals, where our course fits in with the overall PNS curriculum, the course structure, what the bedside sessions look like, and also touching on grading, feedback, and remediation. First, let's take a look at our course goals. So this is a scene of what our students will experience in 4 months. They will be joining clinical teams. They start their ward rotations in January, and we need to think about what skills, knowledge, and attitudes will they need to perform in a successful way on rounds. And of course, it's not just about fitting in with the team. Ultimately, it's really about how our students can contribute to the care of their patients. And that's where we'll kind of start from. That is our objective. How can we, by the time they finish with our course, get them to the point where they can be prepared to join their teams and take care of their patients? This graph describes what they've learned in the first semester on the bottom. They've learned how to take a history, they've learned how to do a physical exam, they've done 4 write-ups, they've done case presentations, and what we're adding to that set of skills now is asking them to increasingly step into the role of interpreting the data that they are collecting. I wanted to share with you a model that was created by Pangaro that describes the stages in the development of the medical trainee. Starting off with the reporter, someone who can reliably and in a accurate way collect information and report it back to you. The next stage is the interpreter stage, where that person is starting to interpret the data they're collecting, and as they progress, they will learn how to manage patients and then be an expert or an educator. So our job is to really think about how our students can go from reporter to interpreter, while thinking about the reporter skills as a foundation. If we go back to this slide, we can see the yellow part of the slide, which is the history, physical, and write-up and case presentation, is the foundation on that the interpretation of data is built on. So making sure those skills are continuing to be developed and are firmed up. And if you think about our course goals and our evaluation, they are intricately linked. The history, physical, professionalism, write-up, presentation, and clinical reasoning is not only our course goals, but those are the exact same things that you will evaluate students on at the midpoint and at the end of the course. So the challenge now is thinking about how we can best prepare our students to enter the ward successfully. So let's think about the PNS curriculum overall and how our course fits into that. This is a schematic that describes the overall curriculum, and we can think about the curriculum as being divided up into 3 chunks. That first chunk is called the fundamentals period. That's the first 18 months. The second chunk is a year long. It's called the major clinical year. And the third phase of our curriculum is a 1.5 years long. It's called differentiation and integration. First, I'll start with the middle section, the major clinical year. These are the ward rotations. They're on medicine and surgery and psychiatry and neurology, etc. These are our classic rotations that they're on. The last 1.5 years, the first it's spent studying for and taking step 1. The rest of the differentiation and integration curriculum, they will be working on their scholarly projects. They'll be doing electives. They'll be doing their sub-internships. They'll be applying and interviewing for residency programs. So doing various activities during that last phase. Now let's look at the first 1.5 years. That is where our course, tutorials, fits in. The first, and you can think of that first section as being comprised of 3 semesters. Semester 1 is anatomy, it's basic science. They started to learn the basics of interviewing. Semester 2, they have their pathophys course, and they also start tutorials. Both of those courses continue into the fall semester. So they've already done 1 semester of tutorials in the spring. They had their summer off, and now they're coming back in the fall to complete their second half of the tutorials course. Let's think about what they're doing in other courses quickly. In their integrated pathophysiology course called BHD, last semester they learned infectious diseases, cardiology, pulmonary, renal, endocrine, and hematology. So they've done a lot of the foundations of health and illness. This semester they start off with neuroscience. It's a long block. It ends in October. After that they go on to their GI block. Then they go on to oncology, and they end the semester with rheumatology and musculoskeletal. And keep note of those dates to help you kind of think about what they've learned so far in their other parts of their curriculum. I also want to alert you to a few important dates when the students will have exams in their pathophys course. Really important to think about. On September 20th, they have an exam on, I believe it's on Wednesday. So, if you have a bedside session on Monday, note that they, have an exam later on that week. And if your bedside session's on a Thursday, they would have had that exam the day before. The second neuro exam is on October 20th, and it occurs the day after our Thursday bedside session. So if you have your course on Thursday, know that some of the students are going to be preoccupied with having to take their exam the next day. Something to be aware of, but our expectations for the students is that they continue thinking and performing in the course just like any other day. And then their GI exam on Monday, 11/13, is the morning of their bedside session. So know that when they show up to your bedside, they might be a little fatigued, something to think about. And also thinking about seminars this semester, there's a course called FCM Seminars where they learn about various topics related to the practice of medicine. And these are the topics they will cover over the course of the semester: evidence-based medicine, cultural competency, substance abuse, palliative care, and end-of-life care. Course structure. Last semester, they learned the physical exam in that blue block called PE 101, and they went to the bedside 4 times. So they did 4 full physicals and histories. They did write-ups 4 times. At the end of the semester, they also did a full physical exam. For this semester, I want us to think about the course as being comprised of 3 main threads. Thread 1 is the focused history and physical, then bedside, then interpreter skills. So there's 3 parts to their intro to focused H&P, a session they're having in the very first week of their curriculum this week, where they're in the simulation center learning about focused histories and physicals, and then they go on to do OSCEs, or observed structured clinical evaluations or examinations. These are when actors play the role of patients. They have 2 cases in the middle of the semester and 1 case at the end of the semester. They have bedside sessions, 9 of them, over the course of the entire semester, and they have several opportunities to learn how to interpret data or think clinically. These are cases called on-call cases, online modules called applied clinical thinking modules. We've also partnered with the neurology and rehabilitation medicine departments to give advanced tutorials on the physical exam related to those topics, and a series called Symptom to Diagnosis that teaches students how to really think about the presentation that you might see and how that relates to a differential. Now let's dive into the bedside sessions. These are the sessions that you guys will be involved with. And the typical ratio is 4 students per preceptor. You should have already received your connector emails connecting you with the students, their bios, and their email addresses. And as I mentioned, there's 9 sessions in total. Uh, let's just talk quickly about how the bedside sessions work. Whether you're teaching on a Monday or Thursday, the sessions go from 2 to 5 o'clock. There's a pre-bedside section, which basically is a time for you to go by and see the patients you're going to evaluate that day. Just double check with them and confirm that you're going to work with them. And also in the pre-bedside section, the student leader of the day may be teaching the group something special. So every single bedside session, one of the students in your group is designated as the student leader. They have a particular educational role that day, and that is going to be communicated to you. It's also in the syllabus, and it's also in the emails that we will send you. But set aside some time for the student leader to do teaching. And I'll give you some examples of what that looks like in a minute. And then what you'll do is you have 4 students working with 2 patients. So you'll take the first pair of students, you'll introduce them to the first patient, and then you'll get them started. Then you'll go to the second pair of students, introduce them to the second patient, and then you'll split your time amongst those 2 pairs. And while doing the history, we encourage the students not to focus on the hospital course. Let's say the patient's been in the hospital for 2 weeks. Don't spend all your time talking about what's happened in the hospital. We actually want the students to imagine that they're at the point of admission, and so that they consider the history and symptoms that brought them to the hospital. During the history taking, one student will do the history, the other student will do the physical exam. For that patient, they will switch roles the following week. After the student number 1 feels like their history is pretty much completed, we ask that that pair of students take what we call a clinical reasoning timeout. That's an opportunity for both students to step outside of the room and say, Mrs. Jones, is it okay if we step outside of the room just for 5 minutes? We're going to talk about what's been happening with you, and then we'll come back and we'll do a physical exam. Does that sound okay? So after saying that, they step outside of the room, and what they do at this time is that they say, what do we know so far about this case? What do we know? What's our differential at this point? And based on our differential, what data do we have? And what data do we still need to collect that helps us argue for or against certain diagnoses? And they also say, well, what physical exam maneuvers do we need to do right now to help explore some of these considerations? And feel free at that moment to look things up. If you want to go online to look something up to help expand your differential, that's great. And then what they do is they come back in, they complete any history that hasn't been obtained yet, and then they transition to the physical exam, which will be thorough, but also will be purposeful, because they'll know how to prioritize based on the differential they've come up with. We don't want the students to be at the bedside for much longer than an hour. So we would say at the latest being 4 o'clock, the whole group, all 4 students, should gather with the faculty member at a place that's convenient, a place that's private, where you can discuss the cases. When you sit down for the wrap-up session, that last hour of your afternoon, you'll hear both cases. Both pairs of students will discuss them. You'll give them feedback on the observed H&P, and you'll also talk through the differential, and you'll ask students what they think. There can be conversations about clinical pearls and also about pathophysiology. Also know that every week there's going to be one student who is going to have a special role of being on the hot seat for giving a more formal oral case presentation. It could be the case that they just worked up, or it could be the case from the previous week. It's up to you how you want to organize that. Also, please make time to review the write-ups from the week before. You would have already given them feedback electronically. This is a chance to also just sit down and hit some highlights in terms of learning points from their write-ups. And you can do that as a group. And also don't forget to give thank you cards. These are cards that should be signed by the students and signed by the preceptor and given to the patient so that we can acknowledge their role in helping to educate the future doctors of our communities. After the session is over, the students will do write-ups. Those write-ups should be independent work. So please be on the lookout for students who are just writing the same thing as their classmates. We want those to be independent. And if you are in a Monday group, the write-ups are due on Friday at 5. If you're in a Thursday group, the write-ups are due Monday at 5. And as I mentioned before, please make comments electronically and email them back to the students. Make sure the students are not using email addresses like Gmail or Hotmail, as those are not HIPAA approved, and to stay with institutional email addresses such as Columbia's that are HIPAA compliant. This is the bedside schedule in terms of the types of activities that will take place at the bedside. And as I mentioned before, there's a student that has a special role each week. So the student's role on week number 1 actually is to review the course goals. So they'll spend about 10-15 minutes making sure everyone's on the same page with respect to the goals and expectations for the semester. And the objectives of each session change every week. So session number 2, the student leader will lead a conversation before going to the bedside about activities of daily living. What are they? And we'll go over those. And then there'll be a special task for the students that day, and that is they're going to ask about the functional status of their patients, and they'll ask them about their activities of daily living. I also wanted to, and these details of what the students will do is included in the syllabus that we will email you, so you'll know exactly what's going on each week. And as I mentioned, we'll also email you every week to keep you up to date. I also want to draw your attention to session number 5. We talked earlier about there being 2 OSCEs, or moments where the students go into the simulation center and they interact with patients. This is going to happen in October and also in November. The ones in October, there will be 2 cases, and that's something we call the mid-semester OSCE. You will not be present for that OSCE, but we will videotape that performance, and the standardized patients will also score it. So session number 5 takes place after their mid-semester OSCE is completed. And so what we want you to do on session 5 is to not actually see patients. On session number 5, you will, instead of seeing patients, you'll sit down with your students, and as a group of 4 students and preceptor, you will review, one after the other, 4 student videos of their performance on the mid-semester OSCE. The students will communicate with the students ahead of time to be able to know how to stream their videos from our system. So we'll work with them directly on making sure all the students know how to do that. What your responsibility is at that session is to make sure that you have some space where you have Wi-Fi and you can stream the videos. And we'll also do some faculty development around how to best give students feedback. So we'll prepare that materials and send that to you ahead of time. These are just some details on what the mid-semester OSCE looks like. And as I mentioned, your expectations on bedside session 5, where you will actually review those videos. Also on bedside session 5, we want you to set aside time at the end of the session to do one-on-one mid-semester feedback. So just meet with one student at a time. The other 3 students can go somewhere else for a moment and spend about 5 minutes or so giving each student some feedback on how they're doing so far. I also want to draw your attention to sessions 6 and 7. These are sessions where students will be they'll be coming in pairs only. So for session number 6, only 2 students will come. On session number 7, the other 2 students will come. They have activities when they're not with you, if they're not with you that week. The reason we do this is so that over the course of those 2 weeks, you'll get a chance to fully evaluate the complete history and physical of each of your 4 students. So on session 6, what's going to happen is student A will do a complete history and physical with you watching the entire thing and with student B watching the entire H&P. You'll give them some feedback, student B will give feedback, and then you'll transition to student 2 or student B, and that student will do the full history and physical with you watching and with student A watching. So it's a chance over those weeks to really get a sense of how the students are progressing in their clinical skills. The caveat to this schedule is for the group at Stanford, only the students, all 4 students will go on session 6. None of the students will go on session 7. If your preceptor group happens to have 2 students, they will only come to you on session 6. They will not be at your site on session 7. Let's talk about write-ups quickly. The write-up should be complete. It should contain all of the elements of the write-up, the chief complaint, the HPI, the allergies, the medications, the past medical history, past surgical history, social history, family history, review of systems. In addition, it should contain the formulation, assessment, and plan, and a problem list. They've already done this last semester. In addition, what we want to add this semester is an expectation on their wards or their major clinical year, which is asking each student to do a literature search and incorporate data from that search into their write-up. And there are basically 4 steps to this. We've communicated this with the students already. So essentially, for every write-up, the student will identify one clinical question they have about the situation. They will identify an appropriate source to look that up. They will read that material. They will synthesize it and incorporate it into their write-up, typically the assessment or plan. And the last point is equally important as all the others. They will cite their source in the write-up. What I've just described from A to D is also described in the literature as exemplifying self-directed learning, or the characteristics of a lifelong learner. All right, now let's think about feedback and grading. As I mentioned, those are the 6 domains of the grade: history, physical, professionalism, write-up, oral presentation, and clinical reasoning. By professionalism, what we mean by that is, are they showing up on time? Are they engaged, even if there's an exam the next day? Are they developing in their skills, or are they kind of checked out? Are they turning their write-ups in on time? Are they putting an adequate effort into their write-ups, or are they blowing it off? So these are all aspects of professionalism. Are they dressed professionally, or are they not, dressed like a professional? So all those things are part of professionalism. And in terms of your evaluation, at the midpoint and at the end of the semester, we will give you a little rubric that you can use. At the end of the semester, we will give you a link where you can upload your feedback for the students. What's so important is that you include some narrative comments so you can help the students improve. Just even a line or 2 can go a long way with improving student performance and giving them some good feedback. And another thing that we will ask you for also at the end of the semester is to make sure that your feedback is timely. And as you can see, the course evaluation is directly tied to our course goals. So where are they getting feedback? So they're getting feedback from you at every bedside session. You're telling them how they're doing on the H&P. You're giving them feedback on the write-ups. You're giving them feedback on the oral presentations. And we also give them feedback during the simulation experiences, those OSCEs. Okay, but the core of the feedback really is what's happening at the bedside with you. At the mid-semester, they have an OSCE. They have a mid-semester feedback with you. And at the end of the semester, they have a final written exam with us. and of course their final preceptor evaluation with you. So if we identify that students are having trouble, we will offer them remediation. Our goal is to try to get 100% of our students ready to successfully enter the major clinical year or their wards. So we want to identify students early who may need extra help. So please reach out to us ASAP if you feel like your student is struggling, either professionally or academically. Early identification will really help us. We're also going to look at the outcomes for the OSCEs, mid-semester and final OSCE, to flag students who may need some help. So if we see some poor performance on that OSCE, I may reach out to you and say, hey, Dr. Thomas, your students, do they look like, one of your students didn't do so well on the OSCE? How are they doing at the bedside? And you might tell me, oh yeah, they're struggling, absolutely, and we can reach out to them. Or you can say, no, this student is outstanding. Their H&Ps are so good, their write-ups are excellent. They might have just had a bad day. So we're going to take all that into account when reaching out to students to offer them extra help. If you're not familiar with Dr. Carol Dweck's work, I encourage you to take a look at it. She has a book called Mindset, which really talks about feedback and how that relates to professional growth or growth in any skill, and not taking feedback or one skill set as being a personal, attribute of one's character, but rather some things that can grow over the course of one's life. And if we can help our students adopt that attitude, they will be more open to accepting feedback and not taking it as a personal criticism of one's character. So if a student is having trouble, as I mentioned, any form of trouble, academic, professionalism, if it's psychological or emotional trouble, please reach out to me ASAP. My email is there. My cell phone number is there. Call me, text me. I definitely want to stay in touch with you. Attendance is required at all sessions. If a student has a sickness, family emergency, religious observation, presenting at a meeting, please have that student email you, CC me, and also CC this email called psfundamentals@columbia.edu. It keeps everyone in the loop. What we ask that you don't do, or the students don't do, is unilaterally arrange switches in your preceptor dates. We do not want that happening. We really respect that you all as faculty have set aside time, have oftentimes canceled clinic to be able to teach this course. And so we want to respect that. If the students cannot make a certain session for some reason, we want them to communicate with me. We'll figure out the appropriate solution. If it makes sense for you to switch the date, that's totally fine. But we don't want the students unilaterally going to you and trying to make that switch. And if a student is absent and has not communicated with me, that's a problem. They should be in communication with us. And if it falls outside of the absence policy, if it's for a reason outside of those conditions that are listed here or that I mentioned, they need to come directly to me and we'll talk about whether we can excuse them or not. We will be in weekly communication with you. We want to hear from you how the students are doing, but also how the course is going. We want to hear your feedback and what you think is working or not working. As you've already had my email address, you have my cell phone. If you're in the area, please come up to Hammer 201. Just stop by and say hi. Second floor of Hammer. Go up the spiral stairs and 201 is to your left. Would love to see you. If you ever want to grab a coffee and just talk about medical education or your own professional development or anything, I'd be very open to that. These are the emails of the Associate Course Director, David Kessler, and of Sarah Wilson, who's the course coordinator, and her phone number. She also wants to hear from you if there's any logistical questions. This course is only as good as the preceptors. Despite all the structure of the course, 99% of whether the course works or not, whether it's true education or not, is really dependent on the quality of the preceptor. It's so much about role modeling, about your own professionalism, your own love of clinical medicine, your own respect for the patient, respect for your interprofessional colleagues, and respect for the students. That's really where they are learning so much, by just observing you. And we thank you for your dedication to educating our students, for your time and your energy. This course absolutely could not run without your commitment to the students. So we thank you wholeheartedly, and we look forward to being on this journey with you this semester. We hope you have a fantastic time with your students, and please be in touch with me if you have any questions or feedback for me. Looking forward to meeting and speaking with each of you this semester. Bye-bye.